Hey, hello everybody. This is Sherry with the CGH Health Foundation, and welcome to our weekly live broadcast. Today is one of the days that we're doing a Growing Healthier program, and these are the programs sponsored by the CGH Health Foundation, where we feature important topics about your health. And these programs are always available on our Facebook channel or Facebook page and on our YouTube channel that you can find at the CGH website. So this month's program is Dr. Buddaraju, who's a rheumatologist with CGH, and he's going to be talking about autoimmune diseases. I want to tell you about next month as well. We'll have Dr. Al Sayed from the Oncology department. He's going to be talking about blood cancers, and that's going to be on September 15th here on Facebook Live. So for today's program, we have a guest host. Dr. Bird is out, so Dr. Kuhns is going to be subbing in for him, and he'll be interviewing Dr. Buddaraju and then doing the regular COVID update. But before I turn it over to him, I want to just let you know that the CGH Health Foundation's Delicious Designs auction is coming up. If you want to put that on your calendar, it'll be online again, and it starts on October 20th and goes through October 25th. And if you haven't already liked the CGH Health Foundation's Facebook page, you want to do that. We have a separate page, and you can watch that for all the details about the auction. The proceeds from this year's auction benefit our new dementia initiative and also our women's health initiative. So with that, I will go ahead and turn it over to Dr. Kuhns.
Thanks, and I appreciate the opportunity from Dr. Bird to participate. These are always interesting. We're going to flip things around a little bit and start with our guest, our Dr. Buddaraju here, so he can move on to saving lives and stamping out disease. So welcome, and thanks for helping out here today, Dr. Buddaraju. So we'll get right into it. How would you define an autoimmune disease and what triggers it?
So to put it in simple terms, when they say an autoimmune disease is basically your immunity fighting your own body. So usually immunity, like basically when the immune cells, when they have like what we call as an immune tolerance. So basically they differentiate between self and non-self. So when they lose this ability, then they can attack your own cells, and depending on which organ is involved and what kind of presentation the patient has. So there is a lot of various kinds of autoimmune diseases. I think there are like over 80 different autoimmune diseases. What triggers it? The common denominator is basically the genetics. I think the genetics play a significant role. Like some people are more predisposed to some autoimmune diseases, some people are not as much predisposed to others. But even with the similar genetic makeup, so what triggers these is there's a lot of environmental factors. So like say for rheumatoid arthritis, people who smoke, they're at a higher risk of developing rheumatoid arthritis versus non-smokers. Then it can be medications. So there is various medications that can trigger autoimmune diseases, like the common blood pressure medications like hydralazine, and some heart medications like procainamide. Then there is antipsychotic medications, even some blood pressure medications like beta blockers and stuff. Sometimes they can trigger autoimmune diseases. And other than that, then there is environmental toxins, like asbestos, and then there is which ones? And also, I'm sorry, I think I have like a mental block here.
Yeah, no, it's all right. One thing I hear come up from time to time is that people are worried about vaccinations causing autoimmune disease, and it's certainly possible, right? You can have
it can, yes. I mean, theoretically it can. So like what the vaccine does in general is basically, okay. So basically what it does is it causes your immune cells to make antibodies. So in case if you're exposed to, say, like you got a vaccine for COVID or coronavirus. So in case you are exposed to the coronavirus, then you have antibodies that can attack it. But sometimes what happens is when they're triggering this immunity, they can drive the immunity too much, and they can sometimes cause these immune cells to attack your own body.
Mm-hmm.
And so it's not a common thing, but it can happen, definitely. I mean, that's the reason, depending on what kind of vaccines you take, people can have like reactions to it.
Is that something you see like on a weekly basis or a few times a year, or what would you say?
So autoimmune diseases triggered by vaccinations is very rare, at least in my practice. If I see like one case a year, I think that would be great, actually.
Yeah.
It's not at all common.
So it's one of those things that's possible, but in practice we just don't see it very often, and I think that would be with my experience too. Probably more see it more often from the diseases itself. Have you seen some autoimmune disease that may have been caused by COVID?
Yes, I've seen. I don't know if I would call it an autoimmune disease, but I would call it like an immune-related phenomenon from the secondary to the COVID. And that's that's the mental block that I had like previously. Like when I was talking about the various triggers for autoimmune diseases, infection is one of the common denominators
Mm-hmm.
they talk about. Unfortunately, I don't think there is any convincing evidence like one particular infection causing an autoimmune disease, but they do think that infection can trigger, like how drugs infection can trigger autoimmune disease. So the patient I was talking to you about, the patient I saw, had like an immune-related cutaneous vasculitis post COVID. So that's the patient I saw. But other than that, I haven't really seen any other patient with systemic autoimmune disorder so far.
Okay, good, good. Okay, so let's go a little bit into the autoimmune disease labs, because I get a lot of people that are in and say, I'm feeling kind of a little bit off, or I'm feeling a little achy. Can you just run some labs for me? And it's always gives me a little bit of pause that we just throw labs at everybody who has some symptoms, because there's, as you well know, there's probably a lot of false positives here, and it's probably more so in this area than in a lot of others. We have to be careful to correlate the clinical with the labs. We can't just throw labs at everybody and have a definitive diagnosis. Can you comment about that, like in terms of the rheumatoid factor and ANA?
Yes, absolutely, you're right. I mean, you can never diagnose and rely 100% on the labs. It's always a combination of clinical symptoms, and in the right clinical setting, I think the labs can help you make a diagnosis. But by themselves, they're not specific. So the two common blood test people order is like, one is an ANA, which basically stands for anti-nuclear antibody.
Mm-hmm.
So ANA is basically like an autoantibody. What it basically means, like, you have these antibodies that are attacking your own nucleus. And ANA is not a single antibody like how it probably might seem when you order the test, but it is actually an antibody against multiple antigens in the nucleus. So that's the reason, like, whenever you get a positive ANA, you try to look into if there is any more specific antibodies, like a double-stranded DNA, Smith, RNP, and all that.
Right.
And so again, it's the same thing. Like with some of these ANAs, I mean, if you look at the literature, so 90% of the patients who have a positive ANA, they don't have an underlying autoimmune disease with it.
I think we should take a moment and pause on that. The vast majority of people with a positive lab test don't have the disease. So they have these specific antibodies, but the antibodies really aren't causing trouble. They're just there and floating around, but they aren't causing you a lot of trouble. Yeah. So I think that's an important thing about the danger of just testing everybody, because if we took 10 people off the street, we might have quite a few of them that, or maybe more than 10, but if we took a bunch of people off the street, quite a few of them would have positive antibodies. And out of the people who were positive, only one of them would actually have a disease for every 10, right?
Yeah, you're right. I think depending on which literature you look at, I think there is like some data out there that says like almost like 5% of the people, they can have like an autoantibody, like if you check for it. As you age, this number even grows higher.
Right.
And other than having an autoimmune disease, that's what you try to rule out when you order the test. Other than that, the other things that can cause or show up as a positive autoantibodies, one is an infection. So even if patient has like say pneumonia or something, they might like, because as I was talking about, like when you have an infection, your immunity gears up, and sometimes they make antibodies obviously to try to protect your body against infection, but at the same time, they might also produce some autoantibodies when the immunity is driven up.
Right.
So chronic infections like hepatitis, tuberculosis, leprosy, all of them, these can cause positive antibodies, including like a rheumatoid factor.
Mm-hmm.
And definitely drugs, as we talked about before, various cardiac medications, blood pressure pills, psychiatric medications, and definitely the newer drugs, like some of the drugs we use to treat autoimmune diseases, like rheumatoid arthritis, like some of the drugs we use, like Humira, these anti-TNF therapies,
Mm-hmm.
they can produce autoantibodies, that they can cause your body to make autoantibodies, and sometimes you can develop autoimmune diseases if it is related to a drug, so like drug-induced lupus,
Right.
which is not an uncommon thing you see with some medications, especially like hydralazine, isoniazid, which is a drug used in the treatment of tuberculosis, and Humira and stuff, infliximab, these are the drugs used for the treatment of rheumatoid arthritis.
So to sum up this part of it, the diagnosis has to be made kind of in a clinical setting that we make sense of things, and then we put together a spectrum of different laboratory measures to correlate that with the disease, and putting all that together, we make the diagnosis, or we say, no, it's probably not, it's something else that's causing these symptoms. So definitely an art to this, and that's why we have people who are highly trained like you to sort this out. But I imagine you spend a lot of time explaining the nuances of this to people. So
Absolutely. I think
all right.
sometimes the fascinating point about these autoimmune diseases is it's shown that people can have like these abnormal antibodies like long before they actually even develop autoimmune disease. So obviously we don't treat a blood test, we treat the patient. So sometimes we might have to just follow them clinically to see like if anything changes over time.
Right. So it may be something that triggers us to follow a patient more closely or keep an eye on them, but not warrant treatment at this point.
Yes, you're right. Absolutely.
Okay. Well, we had a question from Julie Robbins there. She's clarifying that the risk of vaccination for an immunocompromised person is probably less than the importance, more so that flu, COVID, pneumonia vaccines are more beneficial in those of us immunocompromised versus any slight risk of flare. So she's talking about that anything that stimulates your immune system could potentially cause a flare, but that the benefit, especially to an immunocompromised person, generally outweighs that. I think we'd agree with that, right?
Yeah, absolutely. I think the benefit of these vaccinations, especially in immunocompromised patients, is definitely way greater than any possible risk that can be associated with it.
Yeah. Okay. So are there any steps that people can either prevent, reduce their risk, or decrease the severity of their immune response in terms of autoimmune disease?
I mean, definitely, I think, if especially like say if someone has a family history of rheumatoid arthritis, and if the patient is a smoker, then yeah, definitely that's something I would avoid, because smoking clearly has shown that it can increase the risk of developing rheumatoid arthritis. And the second thing is patients who smoke, they don't respond as well to the treatment as
Interesting.
non-smokers. Yeah.
Yeah. So smoking is bad for everyone, but it's especially bad for people who have a family history of autoimmune disease or actually have autoimmune disease. The risk doubles down there.
Yes, definitely. Yes, depending on what disease you're looking at, but definitely in rheumatoid arthritis, yes.
Okay. Well, let's speaking of rheumatoid arthritis, let's move on to that. What are the symptoms? Why is it important to start treatment early in people who do have an established diagnosis?
Okay. So the one thing I'll start out with is interesting thing. I mean, I would call the rheumatoid arthritis the name as a misnomer because I think everyone is under the impression that it is an arthritis. But frankly, it is a systemic illness. So although majority of the patients that have rheumatoid arthritis that present usually with inflammation or joint pains or joint symptoms, you do have a subset of patients that have a different presentation than that. So you can have patients that can present with pleural effusions, like basically with chest pain and shortness of breath. Sometimes you can have patients present with pericarditis, which is basically fluid around the heart. So they can have like chest pains and stuff. But so the common presentation usually is joint symptoms. So the joints usually that are involved are the small joints, usually in the hands, sometimes in the toes, but theoretically any joint can be involved. And the common symptom is usually the pain, then you can have stiffness, and you can always have systemic symptoms like fatigue. Sometimes your patients can be like anemic and stuff.
Maybe we should go back to calling it rheumatism.
Yeah.
Old school. All right. So, no, I think that's a very important point that it's an autoimmune disease that happens to have arthritis as a part of it, but it's not only
Not just
that.
arthritis, yes.
So treating it early, why is that important?
So the key is with majority of these autoimmune diseases, there is no cure for it. So it's almost like treating high blood pressure. So you take a medication, it helps keep your blood pressure under control. It doesn't mean that you're cured of the disease. If you stop the blood pressure pills, your blood pressure can go up, and the same thing holds true. So the key of starting the early aggressive treatment with rheumatoid arthritis is to prevent joint destruction. Unfortunately, once the joints are destroyed, you'll not be able to reverse the joint damage. So anything you're trying to do is to prevent that. So if you look at patients who had the diagnosis made like maybe 30, 40 years ago, unfortunately, they didn't have as many treatments and treatments with fewer toxicities like we have now. And it can be pretty debilitating. Mm-hmm. And so the goal would be is make sure the patient doesn't get to that stage and to maintain their functional status. That's the key.
Right. So, hi, Julie, again. I know Julie well. Would Dr. Buddaraju have time to briefly address what is coming up in new drugs? Well, you were segueing into my next question here. Beyond the currently approved meds, including JAK inhibitors, especially for those with refractory long-term severe disease with major organ involvement. So, there are some people that really struggle and they've been through a lot of medications. There's been a lot of advances in what we call disease-modifying drugs that you're talking about, and there's been some new stuff and some stuff on the horizon. Can you talk about what's new and interesting or promising?
So, I mean, the newest class of medications that we have like 3 of them available right now is the JAK kinase inhibitors. And the interesting thing about these drugs is they're oral medications compared to like the majority of the biological agents, which are injections. Like one of the first biological that's approved is basically the anti-TNF therapies, like the Enbrel and the infliximab or the Remicade. So the newer medications are, and there are newer drugs that are coming out more in the research. And all of these are small molecule inhibitors. So when I say the small molecules, you're talking about these drugs affecting proteins inside the cells versus like these anti-TNF and stuff. These are like receptors on top of the cells.
Mm-hmm.
So like basically you have a cell, you have the receptors on the top of the cell. So these small molecules, I think that's the where we are heading. I think majority of the new drugs that are going to get approved are going to be like small molecule inhibitors. And these are going to be, majority of them are going to be like oral medications. So yeah, this is definitely a very interesting time and a lot of hope for the patients compared to what it was like maybe 10, 15 years ago, I think.
Yeah. So moving away from the old school prednisone, which was pretty effective but had a whole lot of side effects. A lot of these can be much more specific and targeted. And have you seen some evidence that they may be helpful for refractory cases, people who have been through the other medications and are still struggling?
Absolutely. I think with the current medications we have, like in the various proteins they target, I think like I would say, like at least in my practice, I think pretty much like all of them respond to one drug or the other than maybe you might have like one outlier here who doesn't respond as well despite trying multiple drugs. But with the amount of drugs we have, and I think majority of the patients, I think as long as they're compliant with the medications, and I think most of the medications, I think that we should be able to keep the disease under control in majority of these patients.
Right. Okay, well, moving on to systemic lupus. This is sometimes called the great imitator. So it's can be very varied. Can you talk a little bit about presentation of people with lupus and how we treat them?
Yes, I mean, absolutely. I think the lupus is one fascinating illness. So you have like varied presentations for the lupus, but the common presentation is usually cutaneous and musculoskeletal. So the cutaneous, when it comes to the cutaneous, you talk about the rash, which the common rash everyone talks about is the malar rash or the butterfly rash that you see on the face. But you can also see rashes involving other parts of the body, but usually the sun exposed areas.
Mm-hmm.
And then you have the discoid rash, which is a entity by itself. People can have what we call as a discoid lupus, which is basically lupus limited to the skin versus systemic lupus. You can see discoid rash even in patients with systemic lupus. But you do have a subset of patients who have discoid lupus where the rash is, where the disease is limited to the skin. And in these subset of patients, usually the typical antibodies you see in patients with lupus, like an ANA, double-stranded DNA, these can be negative in patients with discoid lupus.
Mm-hmm.
So other than the cutaneous and the joint manifestations, which can be either arthralgias, where you have like aches and pains, or you can have arthritis, where you have like the frank inflammation in the joints, like you see in patients with rheumatoid arthritis. Then you can have lung manifestations. You can get pleural effusions, or you can get what we call as an interstitial lung disease, where it actually involves the parenchyma of the lungs. And you can have heart issues, and it can involve any layer of the heart. So it can involve the lining of the heart, the pericardium, where you can get fluid around the heart. It can involve the actual muscle of the heart, what we call as a myocarditis, where you can have like chest pain and stuff. And definitely it can cause issues with conduction. So basically people can have like arrhythmias and stuff. And it can involve the gastrointestinal tract. It can involve the lining of the abdomen, the peritoneum, where people can get peritonitis. And one of the organs that's commonly involved is the kidneys. And there is various classes. Like, I mean, people can have like a minimal disease to pretty severe, completely destroying the kidneys, that patients end up on dialysis and needing like transplants and stuff. And it can involve brain. And the common symptoms you can see are like the headaches, people can get like seizures, people can have like stroke-like symptoms too, because it can involve the blood vessels, kind of like cause like what we call as vasculitis. So people can have like a stroke kind of stuff. And then people can have psychiatric manifestations too, like either mental status changes, depression. All of these can be associated with lupus. And it's not a common thing, but it can involve the peripheral nerves and it can cause neuropathy.
Yeah. So again, almost anything that can go wrong with you, it's possible that lupus can be involved. So it makes it.
Not a common manifestation, but yes, people it can involve the eyes and it can cause inflammation in the eyes, either uveitis, or it can cause scleritis.
Right.
With basically inflammation in the white of the eye. So.
Okay. Is there a lifestyle component here too?
The key with the lupus, especially when people are already diagnosed with lupus, one thing we tell them is to use sunscreen when they go out and to wear like protective clothing. The key is, as I mentioned before, these people are photosensitive. So when they're exposed to the sun, it's not the skin that gets that you can get flare-ups from the lupus. Interesting thing is people who have a diagnosis of lupus when they have like severe sun exposure. One is obviously there is a risk of flare-up of the cutaneous disease, which is basically the skin involvement, but it's shown that it can also cause flare-ups of the systemic symptoms. So people can have like other organ involvement when they're exposed to the sun, not just the skin involvement. So that's one thing I would tell patients with lupus too.
So sunscreen is part of the treatment for lupus.
Yes.
All right. Yes. Very good. All right. Well, last thing before we move on to COVID stuff, psoriatic arthritis. It's another autoimmune manifestation of arthritis. Can you talk a little bit about how that presents?
Yes. So psoriatic arthritis is basically arthritis, an inflammatory arthritis that can develop in patients with psoriasis. So does everyone with psoriasis develop psoriatic arthritis? Absolutely no. I think depending on, again, which literature you look at, I mean, you can have like from anywhere from like 5-6% of the patients with psoriasis to almost like 25% of the patients with psoriasis that can develop psoriatic arthritis. So the interesting thing is psoriatic arthritis, it has like varied presentations. So one of the presentations is it can present similar to rheumatoid arthritis, which is basically you talk about the symmetric inflammatory arthritis, usually starting out in the small joints in the hands. So the other key is it can present as a monoarticular arthritis, like something like gout. So it can basically involving a single joint. Sometimes you can have like the asymmetric presentation, which can involve like maybe 3 or 4 joints. And the other thing is, in contrast to the rheumatoid arthritis, it can involve the spine. So rheumatoid arthritis, yes, it can involve the spine, but it usually involves the cervical spine. And usually this is a late manifestation. So you're talking about patients who had long-standing rheumatoid arthritis, who are not properly treated or who didn't get proper treatment, those can end up with this inflammation in the cervical spine. But psoriatic arthritis, it can involve the lumbar spine, like similar to, you can have a presentation that's similar to another inflammatory arthritis called as ankylosing spondylitis. And the other differentiating thing with the psoriatic arthritis is it can cause what we call as enthesitis, which is basically inflammation in the regions where like a tendon or a ligament attaches to the bone. So you can have like inflammation in that region. So it can be anything like, say, Achilles tendonitis, or you can get like patellar tendonitis. So these are the various presentations you can get compared to like a rheumatoid arthritis. So they have like 4 or 5 different kinds of presentations. One is monoarticular, which is a single joint. Then you have what we call as a oligoarticular, which is basically 3 or 4 joints. Then you can have like symmetric presentation, like similar to rheumatoid arthritis. Then you can have the axial involvement, which is basically involvement of the spine. And then you can have what we call as an enthesopathy, which is basically inflammation in the region, like where these ligaments or tendons attached to the bone.
Okay. Well, do you have any closing thoughts for our audience here?
What I would say is, I think the key is please don't stress too much on the blood test. I think that's what a lot of patients are worried about. They look at a blood test and they start searching online and they start worrying about it. And I think the key is like any other illness, it's always the clinical presentation. And I think that makes a big difference, at least when it comes to our rheumatological disorders. The labs do help you, but unfortunately, the lab by itself is not going to diagnose. And the second key is majority of the diseases we treat are chronic diseases, like how the conditions you treat, like high blood pressure or diabetes. They need to have like a longitudinal follow-up, because unfortunately there is no cure for it, and early proper treatment is key, because unfortunately, as we talked about earlier, if the joint is damaged, unfortunately there is not much you can do at the time.
Right. Okay. Well, again, thank you for all your knowledge here and your contribution to CGH, and we will move on to the COVID stuff. Let you go on taking care of your own patients, but thanks again.
Thanks a lot, Kuhns.
Yep.
And everyone have a good afternoon.
All
Bye.
right. Okay. So moving on to COVID, before we get into the specific numbers, I thought I'd talk a little bit about just kind of where we're at in general, because it's definitely changed a lot. Was talking to Dr. Easington, our hospitalist, recently, and Dr. Reeder this morning as well. And a lot of people over time have talked about, when does this become endemic versus pandemic? In other words, when does it go from a kind of an acute crisis to something that we're living and dealing with and working with? And my sense is that we're evolving into that. It's from a practical perspective here, we've really seen COVID change both in its presentation and what we can do about it. 6 months ago, a year or more ago for sure, COVID was, when people came in with COVID, it was primarily all the treatment was centered around managing COVID. It was common to have a lot of long-term hospitalizations, a week, a month, because for most people who were in the hospital, not all of them, but for a lot of them, this was their first exposure of any sort, whether it was disease or vaccination. Their body hadn't seen this before, and COVID was particularly good about making this broad inflammatory response that made people really sick and would really linger and relapse. At this point, either through immunization, infection, or oftentimes both at this point, hybrid immunity, we have much better intrinsic defenses. We've seen this before. It's not our first rodeo, so to speak. So more often when we see people in the hospital with COVID, they're coming in because COVID has tipped over their congestive heart failure into trouble, or COVID has caused some other illness they have to flare. And we have to deal with that and treat the COVID. But these are usually things that we can take care of more quickly. They don't have this long, quite the same long tail of dreaded illness and relapses and inflammation and intubation, that sort of stuff. The lung issues and pneumonia are less common. I don't want to say this doesn't happen. It certainly still can, and it's driven a lot by your risk factors. But it's the common thing now, rather than having some people just have a mild course and the people who get bad end up in the hospital and have this often very difficult course. Much more often I'm seeing people by telehealth, and that's still happening a lot. COVID is definitely not gone, Last patient before I took a break for the lunch here was a COVID patient. I know we had 9 patients in for the IV therapy this morning. So we're still seeing a lot of COVID, but because people, one, have seen it before, and two, especially high risk people are doing a better job of getting in quickly and making sure that they get some treatment. Far fewer of the time are we having people go on to the same level of severe lung damage, pneumonia, intubation, multi-organ system failure, the really catastrophic stuff. We are still seeing nationwide around 400 people a day or so die related to COVID, and that's not insignificant for sure. Especially if you're a high risk person and you get COVID, it can be the thing that tips you over for sure. Things have definitely changed. If I can put out a few messages and thoughts about what's important right now, excuse me. One of the other things that's changed that is really critical is we have widely available access to testing. You can get it free through the post office. Most insurance companies are covering this well. Everybody can have a few COVID tests around at home. And probably the saddest thing I see is how many people just don't want to know they have COVID, is they figure they play the odds, and most of the time they get away with it. But we spread it a lot more, and we cause a lot more preventable disease and illness. If I could have one message, is it might seem like you're just having a little flare of allergies or a little cold, but so much of the time that is COVID. And whether or not it's going to get you really sick, you will be contagious for a while. And with these rapid tests everywhere, we could certainly head that off by doing early and often rapid tests. The rapid tests don't always pick up early COVID like the more expensive PCR or molecular tests do. But what they're very good at is determining whether you have a high enough viral load to be contagious. If you have a high enough viral load to be contagious, you're very likely to test positive. So if you're feeling a little funny and you want to know whether you should go somewhere, definitely do a rapid test. If you're going to see a high risk person, maybe you want to do a couple of them to be sure, or do it over a couple of days, because oftentimes if you're feeling just a little under the weather, you won't turn positive right away, but you're also maybe not contagious at that point. But the next day you turn positive, you would know. You may feel a little more symptomatic then as well. But if we can just leverage this widely available testing, I think we could do our community a lot of good to keep ourselves out of trouble, especially with school starting. My daughter went off to school first day of her senior year. Hi, Anna. There's a lot of kids who are going to be in close proximity, and appropriately so, because, again, we have more tools to manage it, and I think the risks overall are less. We're not having the same level of intervention. We still have some risks there that we can mitigate quite a bit just by, if we're feeling in any way a little under the weather, just do a rapid test. And if it's negative, go on with your life. If it's positive, please stay home. I think that could help a lot. Another thing we have that I want to talk about is early treatment. One of the bigger ones here, our first line, is Paxlovid. You've probably heard a lot about that in the news. You've probably heard about Paxlovid rebound. So Paxlovid is an oral drug. It's somewhat similar to the antiviral medications we've used for HIV and other viral illnesses. It's used a little bit like Tamiflu that we use for influenza. What's really critical is it's got to be used early, and that's, again, this rapid testing. If we find out early, if you're a high risk person, and I qualify as a high risk person. I'm over 50. I've got high blood pressure that we treat. So a lot of people who may not think they're high risk are, at least by definition, higher risk to some degree, some more than others. But there are a lot of people that could benefit from Paxlovid, it works very rapidly to decrease viral loads. So people tend to get better pretty quickly with that if we start early. If it's more than 5 days out, the ship has really sailed. At that point, the virus has already caused, gotten pretty well in place. It's caused some inflammation. It's very difficult for Paxlovid to affect the course or a lot of these treatments if you're more than 5 days out from the start of symptoms. So early is critical. The Paxlovid rebound. We know COVID lasts a long time in a lot of people who are untreated in particular. So when you get on it very early with Paxlovid, you may treat the initial viral surge quite a bit, but it's only a 5-day course. And there is some thought that, at least in some people, that may not be long enough to completely stamp this out. And Omicron has changed this some, because Omicron is very good at hiding out in nasal secretions. That's why a lot of people who actually have COVID think they have allergies, because there's a lot of nasal congestion, and it's very good at hiding out there. And it's hard to get medications into those secretions well. So while people tend to feel better pretty quickly, sometimes the COVID can kind of hide out there. And once the Paxlovid prescription is done, it can start to replicate again and cause some symptoms. Usually by that time, your immune system is onto the game, and this is a fairly short-lived rebound. And my experience has been that most people just have to isolate for a few more days and get over it well. In Dr. Fauci's case, he's pretty old these days. His immune system needed a little more help, and he actually got a second course of Paxlovid, which is something that can be done by a judgment call. It's not something that's standard of care yet, but in certain situations may be needed. So talk to your doctor, get in for a telehealth visit. We can usually do that same day and figure out what you need. Paxlovid rebound occurs in about 6% of people by a very recent study that was done. That's somewhat higher than the 1% that was seen in the trials. And we think the difference there is probably related to how Omicron works versus how Delta worked. Delta got into the lungs more and deep down, and wasn't quite so good about hiding out in the sinuses and upper airways. So that has changed a little bit. Still, through current time, less than 1% of people who take Paxlovid end up in the hospital. I haven't had a patient spend more than a single night in the hospital in many months for COVID. And I think that's because my patient population by now is pretty highly vaccinated. And they also get in for early treatment. And between those two things, we're able to keep patients out of the hospital well. And if they do end up in the hospital, we're usually just tuning up some other thing that Paxlovid has, that COVID has tipped over. When I was on call for the hospitalists who take care of people without a primary care doctor, I did see a bit more traditional COVID in people who hadn't been vaccinated, hadn't seen much before, or in particular, people who got their first 2 shots but didn't get a booster or their second booster. There's a pretty good correlation. Whether you're going to end up dead or not may be a different thing, but whether you're going to end up miserable and how long you're going to be miserable, there's a pretty good correlation to how recently you've been either exposed to COVID before or how recently you've had vaccination. Your body, if it had a more recent exposure, one way or the other, has a more recent memory. This gets on top of things more quickly, and you tend to suffer less when you have it in general. The third dose, I think, is particularly important. And I was looking up numbers that only about 31% of the people in Whiteside County have gotten boosted. That's about 65% of people who are over 65. But that booster is pretty important because one of the magic things about leveraging your own immune system rather than just taking a medication to treat something is we get to leverage the magic of the evolution of your immune system. So your immune system has long ago realized that when it sees something again after it's been a little while, as in when you get a booster or you get sick again when you haven't had it for a little while, that the virus may have mutated. There may be variants. So one of the real interesting discoveries has been that people who get boosters or another exposure may have antibodies to Omicron, even though they've never seen Omicron before, because your body is starting to make variations of the antibodies it has in anticipation of there being different variants. So if you've gotten your initial series and you go out and get a booster, your body's immune system will start to make different variations for things that don't even exist yet. You may have antibodies for the next variant that we don't even know about, that doesn't even exist yet, because your body has made slight variations on these antibodies to try and deal with that. Interestingly, this is also how autoimmune disease can occur from time to time, because sometimes these variations of antibodies accidentally target something in our own body, and that breaks bad. But in terms of your ability to resist Omicron and how sick you get, the slight variations like that can help us fight these new variants very well. Because if your body sees a new variant and it has an antibody that it's made that works against that, it can then use that variation of antibody to build on and make a very robust and quick response to that. So that's why if you haven't, I mean, in simple terms, if you haven't had a booster this year, especially if you're 50 or over, you should definitely get one. If you're high risk and it's been more than 4 months, definitely get one. If you've had a recent COVID infection, you're probably also pretty well protected. So I talk about that with my patients on an individual basis. But even one of the interesting things about somebody talked about a new booster, newest booster going to be soon. So if we're talking about the Omicron specific one, that probably will be out this fall. One of the interesting things with this is the existing booster, in terms of especially severe disease, and also, at least for a time, decreasing your risk for any disease, is still working fairly well. It's just time limited. And that's in part because of this phenomenon that your body can make different variants. So there's been some controversy about whether the new vaccination that's specific to Omicron is going to make a really significant difference versus what we already have. We know you make more Omicron-specific antibodies, and that probably helps. But whether that's going to clinically amount to better outcomes is not really clear yet. There was some debate about this in the FDA advisory committee that went to look at the new boosters. Now, they ultimately did get approved because it does look like they're more specific antibodies, and there's probably some benefit, but it may not be huge. And of course, anytime you do anything new, there's always this small chance that there's something we don't know about that new formulation too. So I anticipate they'll be out in late fall. I was certainly hoping that was something we could incorporate into a flu shot. I don't know if that's going to happen, at least in the early flu season, that they'll be put together, but hopefully in the future that can be. But I message to my patients right now who are high risk, we're seeing plenty of COVID in the community, that it's worthwhile getting a booster right now. And then if there's something that clearly becomes better later, to do that then. I don't think that getting a booster now would preclude you from getting an Omicron specific booster sometime later this year. So if you're high risk, don't wait. Early on, before the summer, I did tell some of my patients to see how the summer went, whether we necessarily got a booster early on. I think it's pretty clear now that there's enough Omicron around, and the existing booster works well enough for that we should do that, especially if you're going to do a high risk thing. You're going to go to a wedding, you're going to go travel, you're going to go on a cruise. You want the best protection right then when you're at the highest risk. So getting a booster before you go is good. So I'd much rather have you take a booster before your cruise than wait for the Omicron specific booster later on in the year. I think that it would not be a good gamble to wait in that circumstance. Do we have any other questions? Thomas Greer says hi. Nice to know patients tune in. Thanks, Tom. All right. Yeah, I think that's it for the COVID stuff. We're going to move on to our Daisy Awards. So congratulations to Carissa Kipping, I'm sorry, our registered nurse in the emergency department. Daisy Awards are for outstanding, extraordinary nurses. We have a lot of those there, but we definitely could use more. We'd love to have you. Hospital is definitely hiring. I think the stress of COVID wore a lot of us out. So if you're interested, please come on board with us. And congratulations to Carissa for keeping up the smiling face and the good patient care through this all. Do we have another one? Yes, we have the Sunshine Award for Martin. Martin, I'm not going to try and pronounce your last name. I apologize. Martin's out of the CCU, and he is a CNA, and the Sunshine Award is for particularly good patient appreciation and satisfaction. So thanks for what you do that way. Also a smiling face through this all. So congratulations to Martin. We probably should put up our local statistics just to finish out. I know we used to start with that. I think they're somewhat less critical now in terms of the general infection rate because so many of these things are done through rapid tests that don't get reported. So it's the daily rate isn't quite as helpful as it is before, but even with a lot of those being reported through or not being reported because they're done through rapid tests, we're still seeing a pretty high level. And I would definitely bear this out. I am seeing a lot of people come down with COVID. And it still makes people miserable. It still takes people out of work. So still worthwhile being mindful of the situation that you're in, what level of risk you are. I know we're all tired of this, but it doesn't mean it's still not miserable to get it. So just being kind of careful and mindful and making good decisions, especially about testing early and that sort of stuff. So our community level is unfortunately back to high. Our region 1, it's a region we're in, our ICU beds is 27% that are available. Actually, I think as of the state stuff from this morning, or at least our CGH ICU was full. Interestingly, they said we had 0 beds and 98% capacity. I don't know where we get 2% capacity left from. Maybe we have a closet somewhere. But anyway, right now we're full of a lot of stuff, and we did have, I believe, 5 COVID patients in right now. We had 9 new hospital admissions related to COVID. And unfortunately, 1 COVID-related death this week. So again, still be careful out there, and live your life, but live it wisely. Take good protections, and then enjoy being together and doing the things. So Donna McClellan says, thank you. Appreciate it. We like what we do here and appreciate that we're involved with the community. We are a community hospital. So this is what we're all about. Any other questions, thoughts? Bonnie, hello. Another patient of mine. Julie, thank you. All my patients are checking in. Marianne, another patient. All right. We're happy to do it. Anytime that Dr. Bird is out, I'm happy to be back. And Mary Lindstrom, thank you as well. Unless there are any other questions, we'll call it a day. Be well.